We tried to sort of end the session this morning on a little bit of a lighter note. As you can tell, I'm a very serious person all the time. But to think just a little bit about some so-called clinical pearls that I've had the privilege of picking up, and I'm sure there's going to be a little bit of a difference of opinion around some of them, but just a couple of things to sort of practically help us. We've talked already about the complexity of these treatment regimens that we use, and I think sometimes it really is an art, and I think Caitlin covered this well in her talk as well. Transmitting and translating what you've seen and learned in a clinical trial to your clinical practice can be challenging. And so we always have to come back to this balance of efficacy and toxicity. As I said from the start of this day, safety is paramount. On the other hand, I think, as you'll see in my talk, there are times, I think, where we become so concerned about safety that we can actually not provide a patient what they need. And so hopefully this will be a pragmatic kind of talk to give you a few tips along the way to negotiate the waters. And so I've outlined these 10 clinical pearls. They're not, absolutely going to change your life. You're not going to leave here a new person, but hopefully it'll help a bit with your clinical practice. Right before we dive into the 10, one of the things I've enjoyed so much about my role, some of you know I'd been at Mayo for many years, worked with Prashant and the team, and so many others was great. I had the privilege of just over a year ago joining the International Myeloma Foundation, and it's given me kind of this, what I sometimes call the balcony view of myeloma, because you step back out of a single major institution and you see the players in the field and you see what's happening. And I often get asked, what are sort of the major trends in myeloma? And I'd suggest that here are 6 of them, and some of them are very simple, obviously, that we're using combinations over single agents, that, as we've just heard in the MRD talk, depth of response does matter. It's really striking, wasn't it? In many of those studies, it didn't matter what regimen you got. If you got to MRD negativity, your outcome was going to be better. That's clearly going to influence what we do in the future. I don't think we're going to come to a day where we're just going to give everybody everything. I think we're going to learn, I don't say this to my ID colleagues personally, but I think we're going to learn a little bit from ID and microbiology and be able to test the tumor before we treat it and say, these are the drugs it's sensitive to and these are the drugs it's not sensitive to. Do you not think when you give a doublet or a triplet or a quadruplet that 1 or 2 of those drugs is just sitting on the back of the others? Does everybody absolutely need that? We're seeing that in these studies. There are patients who have single agent. In light of what Andrew just shared with us at transplant, have we not had patients that you've given a single autologous stem cell transplant to go into remission for 6 years and they're on nothing? Right? Sarah gave us a great talk on maintenance therapy, but there are people that get nada. I joke about nada being my favorite drug, right? It's very cost effective. Patients are particularly compliant. The side effect profile is excellent. It's really quite amazing. High-risk myeloma is a different disease. We saw that recently. Some of us have seen this. I saw one of the most dramatic cases I've seen in my life, a tragic situation of a very well-known surgical oncologist who at day 110 after his transplant had the most aggressive form of plasma cell leukemia I've almost ever seen, and he didn't survive. It's just tragic. So we have to recognize that not all myeloma patients are the same. And generally speaking, the length of therapy has been prolonged. Again, I don't go back to you'll take it and you'll like it and you'll ask for more, but we are giving patients treatment for longer periods of time, and that does influence us. And that's why I think Sarah's talk was particularly important to share with us the concepts of looking at secondary primary malignancies or understanding long-term toxicities. These patients, I had a patient the other day who was saying, oh, everything's fine, doc, everything's fine. And of course the spouse is looking at me wide-eyed like, no, everything is not okay. This patient was experiencing considerable long-term diarrhea. They didn't want to come off the drug because they thought it was important. And now the patient is basically housebound and is not going out and visiting with their friends anymore. And if I could be prophetic for a moment, the patient preference world, just like we had patient-reported outcomes has had a big resurgence or has had a big ascension in cancer, I'm going to suggest to you that patient preference studies are going to go up as well, and we're doing this. I had the privilege of being a part of a large one that was presented as an oral abstract at ASH, and it's amazing. Historically, patients have this perception, and physicians have this perception. You know who's in the middle? You know who's closer to the patient? The nurses. When I got accepted to medical school, my father gave me one piece of advice. He was a marvelous physician. He's passed away now from cancer, tragically, but he said to me, Joe, there's only one thing I'm going to tell you. Treat nurses as the professionals they are. And we can learn a lot. And so when we listen better to our patients, we understand what their preferences are. And a lot of times we think it's all about PFS and OS. But you talk to a patient and you do legitimate surveys and find out that their peripheral neuropathy is more important to them than PFS and suffering through it. All right, time's going quickly. Toxicity, as I mentioned, is real and has to be monitored. And quality of life and patient preferences, as you've seen here, has to be respected. All right, what are these? Well, I've already shown you this slide, so I won't go through it again to remind us of the complexity of the disease. But here are the pearls. Dosing of VRD is a dog's breakfast, and you see the rest of them there. We'll repeat them each as we go along just to try and get to us. So why do I say VRD is a dog's breakfast? Because again, I brought together, actually around this weekend a year ago, here in LA, I brought 25 myeloma experts from across the country, and I asked them a series of questions. It was ridiculous. There was actually only one question where everybody agreed on the same answer. But it was incredible how variable this is. So, we heard a great talk from Jonathan on VRD being in many respects the standard of care frontline, although there are alterations on it in many respects. But this is really a very challenging combination. Some people like the lenalidomide for 2 weeks. Some people want the 3-week regimen, a 4-week regimen, a 7-week regimen. It's really quite variable. A couple of things I would say is please always remember really to start the bortezomib, and we were told this in the peripheral neuropathy section, subcutaneously weekly. I might, for an exception of a patient who has raging initial diagnosis with high light chains and renal failure, I may give them the IV bortezomib, the first several doses, often when they're in hospital, to speed up the process. But in general, I generally follow a 28-day cycle with 3 weeks on, 1 week off. Obviously, we can dose adjust that. With the benefit of having that week off, even in the maintenance setting, I do this, because then you can see what happens to the patient in that week off. Does their fatigue improve in that week off? And again, there's no perfect number here because every study has been done differently. I would say most patients can start at 25 milligrams, but some at 15 and some at 10 and maybe even some at 5. I just saw a consult this week of a 93-year-old patient who was insistent on being treated and who was really quite frail, and I'm not going to be comfortable starting her at 25 milligrams of lenalidomide. And so we try to aim at the right level and then adjust. Right? There's benefits of trying to shoot high and come down or shoot low and go up, right? But I think you want to try and target what you think the patient's number is going to be. As I mentioned, consider asking about fatigue in the week off. And I'll come to the dexamethasone in an issue. So in a second. So here's dexamethasone, the drug we love and the drug we hate. Right? When you give patient talks and you say dexamethasone, I mean, you gotta be ready to dodge a few tomatoes, right? Because, we've had a lot of change. Thankfully, one of the most marvelous patients with myeloma who's ever existed, many of you would know Malcolm Katz in his day, but, we had who influenced the ECOG study of high-dose dex versus low-dose dex. It was a patient who made that suggestion. For those of you who are young and don't remember, we used to give dexamethasone 40 milligrams a day, 12 days out of the 28-day cycle. Think about that. Don't do it. Very bad, very bad. I mean, that's a lot of dex. I mean, our patients were climbing the walls, vacuuming at 3 o'clock in the morning. So we know that steroids have a benefit in of themselves, and they also can partner with basically anybody. I try to tell patients, I think of them like the booster rockets on the shuttle. For those first few cycles, they're particularly beneficial and helpful. But then with time, you can't keep those patients on 40 milligrams of dex a week. I mean, you can, but for many of them, they are really going to suffer. And that's why I thought the presentation of the study, when Jonathan talked to us about the RD continuous versus RD and then switching over to just R alone, was really important. Because I really try to minimize the dex in my patients. We all know that dex comes with a whole series of challenges, right? Whether it's immediate ones in glucose and blood pressure, long-term ones of cataracts and bone disease, and a whole series of things that can happen. So I start at 20 in my more frail patients instead of 40. And here's an interesting tip for you that we found, and I know it's been kind of the Mayo experience in a few other places. Somewhere around a fifth to a quarter of patients actually may benefit from getting their dex at night instead of the morning. So I ask every patient, once they've been on Dex for a month or so, when do you get that jittery feeling? When do you get all wired and excited? Or you look to the spouse or the partner and you ask and say, when are they a pain in the tuchus, right? When does that start? Does that start, an hour or two after they take the drug? Okay, then they should take it in the morning. But for some, there's a delayed effect. They're like, I'm totally fine all day, doc. And then 5, 6, 7 p.m., I really get wired. And I say, well, let's do a trial. For the next 4 weeks, take it at night and see. And for some patients, that has really been revolutionary for them. And of course, the lesser known side effects we need to keep a very close eye on. Does depth of response pre-transplant matter? Some guy named Prashant Kapoor, Prashant's here, published an excellent study looking at, indeed, if you have a deeper response before transplant, you're going to do better. And I get that, but part of it is like saying, okay, I'm a runner, and we're going to say, I'm going to evaluate the next Los Angeles Marathon. I'm going to see all those people that are winning at the halfway mark. Is that predictive of who's going to win in the long run? Well, yeah, of course they're going to do better because they're better runners, right? So I know this is a really deep statement. This might be the deepest statement you're going to hear today. Patients who respond, right? Wow, intriguing. So the challenge here is, yes, we know that you want to get a depth of response because we know to some degree that correlates to a deeper response with transplant. But be careful, and most of us would at least want a partial remission. But be careful of that patient who, for whatever reason, has the kind of myeloma where maybe they're not as responsive to some of the novel agents. And I see patients getting switched. Oh, well, they've gone from VRD to KPD to DPD. I mean, they get changed all these regimens. My usual approach is you're allowed one mulligan, right? I mean, one didn't work, use a second regimen. And then take them to transplant, because transplant can be the equalizer and can indeed really help. And furthermore, you have options after transplant. We know that after transplant, there's a sensitivity to certain kinds of therapy. To consolidate or to not consolidate. You remember that there are differences between induction, consolidation, and maintenance. We focused on maintenance today, but remember the concept of consolidation is a response phenomenon. Maintenance is a survival phenomenon, right? I try and teach the medical students, I say, there used to be these things called envelopes, and we used to actually write on a piece of paper this thing called a letter, and we would put it inside, and believe it or not, we'd put it in this blue box, and it would magically appear in someone else, like letters. And so putting a stamp on an envelope is like induction therapy. Consolidation is where you really push it down with your thumb, and maintenance therapy is kind of just keeping your hand over it to make sure it doesn't fall off. The consolidation is meant as a depth, whereas the maintenance therapy is a duration. And so now of late we see all these studies, primarily European studies, looking at should we consolidate people after transplant. And I think the best evidence we have for this is when they haven't had optimal frontline therapy. This is where we've even seen the double transplant, right? The tandem transplant that we almost never do anymore. Right? I mean, when I think of tandem transplant, I think of my poor patient who's barely treading water, has just gotten their head above water. I'm like, welcome back. And you push them right back down again, right? I'm not saying transplant is evil. Sorry, Andrew, I know you're a transplanter too. But, we really don't have extraordinary evidence for stem cell, for a double transplant, especially if they've had good induction regimen up front. And we see this in the Stamina study, where patients were randomized after a single transplant to just go straight to Len maintenance, to have another transplant Len maintenance, or to get more consolidation and then Len maintenance. And there's really no difference in the outcome. So in general, most of your patients who have achieved a VGPR or better after a single transplant can go straight to maintenance without extra consolidation. Neuropathy is a cancer, don't let it grow. And I know this was already stated, and Caitlin covered it really well, and I'm being a little bit part of the redundancy of the Department of Redundancy Department, as I say it. I don't want to emphasize it too much, but this so impairs a patient's quality of life. And this notion of trying to prevent it off the start, communicating with your patient, I'll come back to that in a moment, adjusting and stopping or switching. And in my experience, it's not so much the dose of the bortezomib as the frequency. So my first move, if there is any sense of neuropathy, is to reduce it to every other week. But generally speaking, once you start seeing a neuropathy emerge with bortezomib, chances are you're going to have to make a significant adjustment. Carfilzomib in the heart, the untold story. And we've heard a little bit about this already, but I think there was pretty clear agreement through the discussions today that, carfilzomib, that one question, by the way, that every myeloma doctor agreed to, is that the potency of proteasome inhibitors was carfilzomib 1, bortezomib 2, and ixazomib 3. They're three fantastic drugs that are used in different ways in different capacities. Carfilzomib is a particularly potent drug and very effective, so we don't want to not use it when we can, but at the same time we want to appreciate that there is a toxicity. I think most of us are seeing now, if you can do three things: be very careful with your fluid management, control their pre-existing hypertension, and manage their heart failure if they have it in advance, that risk of a significant issue goes from 7 to 8% down to about 2%. So it is a small signal. It's there, and we need to watch for it and walk them through the tumor lysis, as we heard already. And if there's a concern, think about cardiology. Don't miss cardiac amyloid. That's something that we sometimes miss. I don't routinely get an echo on every patient before starting them on carfilzomib, but if I have concerns, I will do that. Don't be rash with immunomodulatory drugs. So I very frequently see patients come in from the community, a patient had a rash, therefore you're allergic, thou shalt never have an immunomodulatory drug again. We can't do that. I would say that the majority of those patients who develop a rash on an immunomodulatory drug can actually continue on it. And in general, hold it for about a week, give them a few days of steroids. You can reinstitute the drug, sometimes at the same dose, and sometimes at a lower dose depending on the severity and their tolerability of it. And please don't call them allergic to it, because I think we're going to deprive them of serious things. And it goes back to the same principle of the second primary malignancies and others. There's a devil you know and the devil you don't, right? I mean, a patient's got an incurable malignancy in front of you. That's tragically what is likely to take their life. And so we want to balance that efficacy with toxicity. POM is the bomb. Use it intelligently. I mean, right now, pomalidomide is the most promiscuous drug in multiple myeloma. Everybody's trying to partner. We saw it, all the studies that Andrew and others showed. It's partnering with elotuzumab, and now isatuximab is partnering with daratumumab. It's partnering with carfilzomib. I mean, everybody wants a piece of POM. And this is a drug that has a tremendous history in myeloma. I had the privilege of helping develop this agent back in the day. I think I'd treated about 320 patients before it was even FDA approved. So we had a lot of experience with this drug. I'll tell you that more often than not, I'm using it at 2 milligrams and not 4. We actually did a 2 versus 4 study at Mayo, and there was really very minimal differences in efficacy, but there was more toxicity with the 4, especially because we tend to use it in combination. And so it'll be interesting to see what happens with sequencing, because I think we're going to see, and the Emory group has been advocating this, we're going to see earlier use of POM, and it may influence what's going to happen in the later categories. Respect or disrespect cytopenias. The simple point here is don't treat myeloma like a solid tumor. Right? If you have a solid tumor practice where cytopenias mean it's caused by the drug and you really have to withhold and wait, I mean, if you wait for every patient myeloma to have a neutrophil count over 2, you might never treat your patients, right? On the other hand, obviously, we don't want to be completely cavalier. And it's hard, especially if patients are on anticoagulants or something like that. But, we get a little callous with this, and I want to be careful. They call me and say, oh, Dr. Mikhael, the patient's got a platelet count of 8. And I'm like, that's like 2 for each limb. That's like pretty good. I'm a bone marrow transplant. They're like, whoa, do you want me to freeze them and use some of them for my patient? No. So I'm obviously not, I don't want to be facetious that way, because that's a serious situation. But, we want to be careful to not overcall treatment, because toxicity, because very often this is because the marrow is filled with myeloma. That's like saying I'm not going to put weed killer on my lawn because I'm worried about hitting the little bit of good lawn that's left. Well, you got to get rid of the weeds first. But you do want to be cautious and get people through it, and use growth factors when possible. And last one is don't kid with your kidneys. Dosing in kidney dysfunction is important, because remember, half of patients at some time in their myeloma career are going to have renal dysfunction. And so you want to be careful with that. I think one recent, I'm biased obviously because I published the paper, but we did a precog study. It was what I called the 7-year pregnancy. It took a long time to get this baby born, but we finally got the study done. And we looked at the dosing of lenalidomide in patients with renal failure, even those on dialysis. And the short version is, if your patient's got a creatinine clearance of greater than 30, they can actually get full dose len. If they're less than 30, You should still give it to them daily, even if they're on dialysis. This 3 times a week business is probably not necessary. You can give it daily at a lower dose of either 10 or 15. And this is my final slide, and one of the slides that now I include in almost all of my talks. Some of you, I'm sure, are familiar with this as a plenary at ASCO a couple of years ago and then published there afterwards. It's kind of a nice way to end a myeloma session. This is an interesting randomized study. They took solid tumor patients and they randomized them simply to 2 groups. One group got iPads to communicate more routinely and effectively with their healthcare team. And the others just were the standard of care. Call, leave a message, nurse calls you back a day later, or whatever else. They were hoping to show that enhanced communication would improve the quality of life of their patients. What they didn't expect, almost like those palliative care studies, it actually improved the survival of their patients. So I try to teach, especially our young physicians coming forward, yes, get to learn all the fancy schmancy drugs, but talk to your patient. Listen to them. They're the key to this. And if we don't do that, if we get so caught up with MRD, no disrespect to our 2 speakers here, and getting caught up with the technology, I've got this next generation sequencing that can do this, that's good, but listening to the patient and adjusting your treatment course and adjusting for the toxicities is absolutely fundamental to the practice of medicine. And we do that as a team. There's no one person that can handle this whole thing. And I know many of you don't have access to all the members of the team. Whatever team you have is critical, I believe, in caring for our patients.